Welcome to Cardiac Sciences Grand Rounds. I am Satish Raj, pinch hitting for Carlos, who's busy stamping out atrial fibrillation as we speak in the EP lab. Today, we're lucky to have Bill Kent, one of our cardiac surgeons, give us our talk. I think he's, known for many things. He really, I think, developed our program in minimally invasive valve surgery. He leads our program in mechanical circulatory support, or the LVAD program. But despite as many things as Bill can add to his CV, I will always think of him as the best dressed man on the 8th floor. He's always very sharply attired, seemingly even right after a case. It's quite amazing. Today, he's, I think, going a little off script from the things that I know him for primarily, and he's, I think, taking us back to learn again about the Ross procedure, a surgical option that maybe involves a little less mechanical stuff than what I usually think of Bill is doing. I'm sure we'll have a great time. Bill?
Great. Thanks, Satish. Thanks for the very generous introduction, and thank you to everybody for making time for this morning. So today I'd like to talk about the Ross procedure. This is an operation that was done at Foothills for many years with Dr. Andrew Maitland, and we've just reintroduced it in the last year. So the outline, we're going to talk about the Ross procedure and what's the rationale for doing this operation. We'll look at the technical evolution, and really this is what's changed a bit with this procedure over the years. There's some new technical modifications that make this procedure, we believe, more durable than it was in the past. We'll review the contemporary outcomes of the Ross procedure, look at the indications, and we'll summarize things at the end. Donald Ross is pictured on the right. This was a few years before his death in 2014. He was a South African surgeon who worked in London. And this is him with Paul Stelzer. Now, Paul Stelzer is the highest volume Ross surgeon in the US of his generation. As I was reviewing these slides this morning, I was looking at his tie. Don't know about that tie, but anyway, great guy. I've met him a few times. This is a modern day picture of Dr. Stelzer on the left. And this was a picture taken from his Ross master course that he does with Ishmael El-Mamsi. Ishmael is on the right, and Ishmael is a Canadian. He is really responsible for the resurgence of the Ross procedure over the last 10 years. He worked he did his PhD in London with Meg Diacoub, and then he came back to Canada and established his program in Montreal. He's a great guy. He's got, many of you have heard him speak. He has tremendous enthusiasm. He has produced the data, and he's, his enthusiasm and passion for this operation are really what has allowed it to grow and for us all to realize the true benefits of the Ross procedure. So he deserves a tremendous amount of credit for that. Now in Calgary, Andrew Maitland, pictured in the center, of course, who retired a year ago. We all know Andrew. He did about 50 Ross procedures. I was lucky enough as a resident to work with him on doing about 3 Ross procedures. So he taught me a tremendous amount, both then and as we got the program underway here. We did our first case in February of 2021. Scott McClure has been my partner in this, and Scott's, as you know, he's a tremendous surgeon, and he's a tremendous colleague. And so it's been a pleasure to work with Scott on this. We've supported each other and learned together. This started in 2018 when we attended the Ross Master Course in Montreal. We are in this big picture. I don't want to point us out because we flew. We worked the previous day and took an all-nighter to get there for that course. We looked terrible, but anyway, it was worthwhile. It was a great course. It's a 2-day course that is part didactic and part doing the operation on pig hearts. We learned a tremendous amount. We came back to Calgary. Scott and I traveled around. We observed 3 different surgeons do the procedure. We then, with Dr. Maitland's help, did the procedure on human hearts in the autopsy suite. And there we are doing one prior to our first case. Now let's talk about the Ross procedure in a little bit more detail and what's the rationale for this. I asked Ishmael, I emailed him and said, do you mind if I use some of your slides? Because he does such a good job of presenting the rationale for the Ross procedure. So a few of these slides you may have seen before, but the point here is that the native aortic valve is a living structure with complex functions. It's much more than just a trap door of three cusps sort of thing. So, the aortic valve and the aortic root, which is a living structure that promotes laminar flow out of the heart. It has excellent hemodynamics. There's low thrombogenicity and resistance to infection. Yes, we see infection in the aortic valve, but it is relatively rare given the nature of its structure. The prosthetic aortic valve, on the other hand, has drawbacks of thrombogenicity. It is susceptible to infection, and one of the most dangerous and highly morbid things that can happen is an infection of a prosthetic aortic valve. Hemodynamics are suboptimal. We do produce gradients when we put in a valve with a sewing ring and with struts and rigid structure. It also produces non-laminar flow. So these lead to valve-related complications, and the consequence of that for our patients is a reduction in survival and quality of life. So the goal with the Ross procedure is to take a living aortic valve substitute, and as a consequence of that, improve clinically relevant outcomes for our patients. And I think that over the last 10 years, we've really seen data to suggest that that's true. Now, before we move into some of that data, I want to talk about conventional AVR. And we have to look at the advantages of conventional AVR, because this is, of course, the alternative operation. Certainly, it's standardized. Every cardiac surgery trainee that comes out of training knows how to do an aortic valve replacement. It's easily reproducible. Most cardiac surgeons are completely capable of doing an aortic valve replacement procedure. Relatively short operative times. That's certainly an advantage. Being on a heart-lung machine for prolonged periods of time does come with risk. And we have long-term data. As someone who has a bias in minimally invasive surgery, the other advantage to me is that aortic valve replacement can be done in a minimally invasive way through mini thoracotomy incision. So all those are advantages of conventional AVR. However, we have to look at these advantages and disadvantages relative to patient age. And there's one big disadvantage to conventional AVR, and that is associated with long-term mortality. It is a lot of years that young patients have to have a prosthetic valve, and there are consequences to that, most importantly, mortality. So let's look at that. This study was done in Montreal Heart Institute. I have a lot of friends at the Montreal Heart, and I think they do a tremendous job of cardiac surgery. One of the things that they're very good at is following patients. And they have a dedicated valve clinic. When Andrew Maitland and I set up our valve clinic here, a lot of that was inspired by the experience in Montreal and how they're able to follow patients carefully over the long term. That allowed them to do this study. Ishmael did this study when he came back from his fellowship, published in 2014, followed 469 isolated mechanical AVRs in patients under 65 years old in Montreal Heart Institute. They're isolated AVRs, but in all comers. Follow-up was 95% complete in their valve clinic. These were young patients, so he's looking at a young cohort with a mean age of 53. It is sobering to see what the long-term survival is. I mean, we often put in mechanical valves and think patients do very well over the long term, but that's not always true, and we don't always see the consequences. But if you look 10 years out, survival, 87%. So that compares with the matched survival of the population of 94%. At 14 years, you're looking at only 78% survival. If you add that to reoperation, again, these are sobering numbers. At 10 years, only 82% of patients are free, and these are young patients, again, to make the point, 52-year-old mean age. 82% of them have either had a reoperation or have died. And, so that's 1 in 5 patients is dead or reoperated within 10 years. Now, a lot of this data is driven by death rather than reoperation in the mechanical valve cohort. So significant data. What about tissue valves? There's certainly the trend lately to place tissue valves in younger patients with the thinking, I think it's flawed thinking, but we won't get into that today, but that the tissue valves are a better choice for younger patients because they allow the option of a valve-in, valve-TAVI procedure in the future. If we look at long-term survival and consequences in a young patient population of having a tissue valve, again, it would suggest that our survival outcomes are even inferior to mechanical valves. So this is a large cohort study, single center French study done from 1984 to 2008, looking at the perimount tissue valve. So that's essentially the Edwards valve that is the most commonly used valve in most centers in North America. And that shows excess mortality in young adults. This is looking at observed to expected. So this is OE ratios of patients looking at what their expected survival would be relative to what was found when these patients were followed longitudinally. It's striking. The patients under age 50, really they lost 20 years of life as a result of having a bioprosthetic valve. And, the survival, the observed to expected ratio improved with older cohorts, but in young adults, certainly evidence of excess mortality. A really great study came out, and this was a study from California, registry data, large population of patients published in 2017 in New England Journal of Medicine by Joe Wu at Stanford as the senior author. And this looked at excess mortality, again, in young patients. So patient group 45 to 54, looking at mechanical versus biologic valves and probability of death. Also looking at larger age group between 55 and 64. So this is the cohort of patients that I think benefit the most from the Ross procedure. Again, we're looking at 15-year mortality in this young cohort of 26 to 30%. This is even more than was found in the Montreal registry. And that group of patients was followed carefully at the Montreal Heart. This is registry data from California, so it's more real world data. And the 15-year mortality in patients aged 55 to 65, again, 32 to 36%. So certainly significant. So some may say, well, that's understandable. This is old valve technology on the mechanical side. And there's been advancements in the development of mechanical valves with low thrombogenicity. And so this is the PROACT study. And this is looking at low anticoagulation with the Onyx mechanical valve. And this is the 5-year results, which were recently published. Again, this is 41 US and Canadian centers. Patients enrolled in Edmonton and Vancouver, 375 patients, and looking at patients managed with low dose warfarin with an INR between 1.5 and 2. And the findings from the PROACT trial was there was no difference in thromboembolism, but bleeding complications were less if the INR was decreased. Even with that, the INR of 1.5 to 2 resulted in 5.5% per patient year incidence of the primary endpoint, which is death, bleeding, thromboembolism, and valve thrombosis. So, yes, with a lower INR, we may have the potential to reduce the risk of bleeding, but when you look at composite outcomes, valve thrombosis and bleeding is always going to be a complication associated with being in anticoagulation with mechanical valves. This was a valve I explanted not too long ago. This was in this one, in fact, was in a patient who stopped taking his anticoagulation because, well, he told me he drank a bottle of vodka every day and he figured that was enough to thin his blood, but clearly not. But, you know, I've taken thrombosed valves out of patients with therapeutic INRs. I've taken them out of patients who were bridged from warfarin to tinzaparin for procedures. The reality is a mechanical valve is always going to have a risk of thrombosis, and when you do see it, it is profound, and that's an example of what you would see intraoperatively. As I mentioned, the Ross procedure has had some technical refinements over the years, and that is part of the reason for its resurgence. So let's talk about the technique so you can understand the Ross procedure, and then we can talk a little bit more in detail about some of the refinements of this procedure. It was introduced, it's not a new operation. It was introduced in 1967 by Dr. Donald Ross. He was the first surgeon to actually do this surgery. It was the idea was suggested by Shumway a few years earlier, but this was the first publication. The operation is begun by resection of the aortic valve, the diseased aortic valve, and many of these patients are bicuspids. We'll talk a little bit more about that in a minute. When the aortic valve is resected, we sort of stop there and we have to see whether the pulmonary valve is adequate. Now, in the case of patients with bicuspid valves, and most series would suggest that at least 50% of Ross patients are bicuspid valves, you might wonder, well, what's the incidence of a bicuspid valve in the pulmonary position? So, you know, we open the right ventricular outflow tract and examine the pulmonary valve before we harvest it. Now, the incidence of bicuspid pulmonary valve is only 1.1% of the population, as opposed to a bicuspid aortic valve, which is 2% of the population. So much, much lower incidence. Interestingly, having a bicuspid pulmonary valve is actually not a contraindication to going ahead with the Ross procedure. In some cases, that does make sense, and it's a more durable conduit than it would be than the alternatives would be, especially in children. But anyway, after the pulmonary valve is examined, if there aren't any significant fenestrations, I think fenestrations or tearing at the commissures is probably the most common reason for backing out of a Ross procedure, but fairly uncommon. I spoke to Ishmael in his series of over 500 patients. He's had to back out of only 4 as a result of fenestrations of the valve or inadequate autograft. The autograft is then sized. So we want to have the right size match between the pulmonary autograft and the aortic annulus. Now, if there is a size mismatch and the aortic annulus is too large, then we'll do a downsizing procedure, which I'll tell you about in a sec. So the sizing is done there, and this is a picture, intraoperative picture of what the pulmonary valve looks like. Beautiful valve, 3 leaflets, very thin, mobile leaflets. Looks exactly like an aortic valve, except the commissure is a little lower, so it's a little shorter valve than the aortic, but otherwise it adapts well in the systemic circulation. The valve is implanted by interrupted sutures placed deep in the annulus. This is another technical refinement that sounds like a small detail, but I think it's important for the success and long-term durability. It used to be that you would sit the valve a little bit supraannular above the annulus. Well, the fibrous structure of the heart is around the annulus. So you want to keep this valve intraannular to prevent it from dilating over time. And the technique is to bring the sutures below the annulus to bring that valve into the environment of the fibrous skeleton of the heart to prevent autograft dilation in the future. So this is done with simple interrupted stitches. Scott and I, as we learned this procedure, one of our most valuable resources was our tremendous assistant Angela Leski, and she worked with Andrew on all his Ross cases, and she's been probably the most important person for us in learning this operation in the operating room. And a lot of that is handling the sutures. I mean, this amounts to somewhere between 40 to 50 sutures and managing them. So this is an intraoperative photo from a recent Ross procedure as Scott and I are trying to handle the sutures and make sure that everything's kept in order. Following implantation of the autograft, then the coronaries, of course, have to be reattached to the new root, and that's done in this fashion with a running stitch. There's a picture of the pulmonary autograft implanted. Again, a nice picture showing the beautiful, living leaflets of the autograft. Now, of course, as a result of harvesting the autograft, you have to replace the pulmonary valve, and that's done with a homograft. This is another technical advancement. In the past, homografts were used that were not decellularized, and there was a certain percentage of patients that developed an inflammatory reaction after surgery, and as a result developed pulmonary stenosis. That tended to happen earlier, and some patients were more susceptible than others. So we now use decellularized homograft. It's cryopreserved. We order it from the cryopreservation lab in Atlanta, and it's shipped to us. The other thing is we tend to use larger homografts to prevent that risk of pulmonary stenosis. So it used to be common. I've seen some of Andrew's operative reports actually where he used a 26 valve. Now we use nothing smaller than a 28 to 30. Most of ours have been 32. So that's two of the strategies we've used. This is trimming off the bifurcation of the pulmonary artery. Okay, and that's this is the valve end. So this is the homograft flipped around. You can see the valve leaflets on the inside collapsed. This is implanted with a running suture line, as is shown in the diagram. And there's the completed procedure. Now, this was an intraoperative photo taken from not too long ago. As I mentioned, I'll show you the anatomy here, the pulmonary homograft here, and of course the pulmonary position. As I mentioned, a lot of these patients have bicuspid valves and associated aortopathy, so a large percentage will require replacement of the ascending aorta as well, and this is done with Dacron. That's the replaced ascending aorta to orient yourself, the right atrium and the right ventricle. And I hope this plays. It's so here, here's the completed procedure. I mean, this is there's a lot of satisfaction when we do an operation like this, and you see the see if I can get this to run. The heart beating in a and on echo. It's an elegant operation. It looks beautiful on echo too, with new valve leaflets, which on echo you can't tell the difference between a native aortic valve. So I think a really good option for young patients with great durability. And now let's look at more importantly. So what's the data to show that? And this was written by Magdi Yacoub and Ismail El-Mamsi in I believe 2010, after he came out with that data suggesting durability over the long term, which I'll show you in a sec, suggesting that underuse of the Ross operation was lost opportunity. So in the U.S., according to the STS database, the Ross was very underused, and in fact, less than 1% of patients who went for AVR got a Ross procedure, according to the STS database. And so this article was suggesting it's the only operation that guarantees long-term viability of the aortic valve substitute. It has the potential to reproduce the elegant, sophisticated functions in normal aortic root, which translates into clinically important endpoints such as enhanced survival and quality of life. So most importantly, let's look at the contemporary outcomes and review the evidence. If one paper would have turned the tide the most, it's this paper. This is the only randomized controlled trial looking at two options for aortic valve replacement. And when this was done by Magdi Yacoub in the UK, it was done with a homograft versus the Ross procedure. At the time, it was believed the homograft might have good durability over the long run. As a result, we've seen that the homograft does not have the durability that we thought it was. But these patients were randomized to Ross procedure versus homograft. And the striking thing here is the Ross patients had no difference in long-term survival when compared to population matched controls. On the red dotted line, those are the homografts that had a survival, a mortality that was greater over the 12 years of study, but the Ross patients had equivalent to population match. So this was had not been demonstrated in a randomized trial before, and certainly this led to sort of the enthusiasm for the Ross procedure and started its resurgence. Toronto study, this is Tyrone Davids, a surgeon. So this is primarily a single surgeon experience, but it's a large cohort of patients. Longest longitudinal study looking at Ross outcomes that we have, 258 Ross patients, propensity matched to 1,400 mechanical AVRs, 205 propensity matched pairs from 1990 to 2014. So if you look at cardiac and valve-related mortality, that favors Ross patients over aortic valve replacement over a long follow-up period. If we look at stroke or major bleeding, not surprisingly, very minimal in the Ross group and much more significant, particularly driven by the mechanical aortic valve patients. Interestingly, this study also found valve reintervention was, and this doesn't quite fit with a lot of other studies. I mean, again, this is single surgeon, excellent surgeon doing these procedures, but finding that the reintervention was very low at long-term follow-up in the Ross procedure at 87%. And it was not statistically different than AVR. This is a paper from Australia. This is a cardiac surgery database, 275 propensity matched pairs, mean age of 52. So these are young patients looking at 30-day mortality between the two, Ross patients versus AVR, both comparable. And I think we can, there's been some debate about this. We can say though that at experienced centers, the perioperative mortality rate for these operations is very low. And even though this was Australian cardiac surgery database, this is primarily a single surgeon who was doing the Ross procedures, and that was the lead author, compared with a much larger group in the overall database. Looking at outcomes, so there's obviously some selection, and there's selection bias with all these cases, but I still think you're looking at a large cohort of patients with excellent long-term results with the Ross procedure. So looking 10 and 20 years out, favoring the Ross procedure. 66% more likely to be dead after a mechanical AVR when compared with the Ross procedure. Aortic valve replacement in children and young adults. This is a UK registry study. So again, looking at, this is sort of real world data. And they stratified patients according to age and also according to their procedure. So whether it was a Ross, mechanical AVR, tissue AVR, or homograft, they made efforts to propensity match these groups and looked at events, thromboembolism, stroke, bleeding, re-intervention, and death, and found with that composite outcome that Ross came out ahead of mechanical AVR and particularly tissue valves. So in addition to that, Ross was the only group out of those three that had survival comparable with the matched general population. Now, of course, always with surgery, it's difficult to obtain randomized studies when you're looking at things. Surgeons always have, when they start doing a procedure, believe so much in it that it's, they're not willing to randomize patients. And so that's one of the reasons that randomized studies are so hard to run. But some quality data comes from systematic review and meta-analyses, and this was done by Amin Mazin, and he is a resident in cardiac surgery in Toronto who has done a lot of papers with Ishmael, and they've done great work together. He's done a tremendous job in writing about the Ross procedure, and he published this in 2018, finding 18 studies, mean follow-up of 6 years with the Ross procedure, lower all-cause mortality, lower stroke, lower major bleeding, but with the higher rate of reintervention, and that's particularly relative to mechanical aortic valve replacement. So let's talk a little bit about that. So is reoperation the Achilles heel of the Ross procedure? Mechanical aortic valve replacement, which is the alternative for many of this young cohort, has a lower risk of reoperation. So is this a problem? Well, what is really the incidence? So if you look at Sievers, German surgeon, German aortic surgeon, lots of experience in Ross procedure, 630 patients, mean age of 45, so young cohort, good long follow-up. Many of these, 25%, had pure aortic regurgitation with a generous annulus size, and 77% were bicuspid valves. And following his results, the risk of reop, 0.6% per patient year. So 10% at 20 years, roughly. So 80% of these patients were good. So had minimal deterioration of the autograft. So not a high incidence of reop. That's pretty good, especially relative to a bioprosthetic. Tyrone David, his series in Toronto looking at reoperation. Long-term follow-up, 212 patients, mean age 34 years. Autograft reoperation, only 11% at 20 years. So these are low numbers, but keep in mind these are experienced surgeons and very experienced centers. Some of the predictors of requiring a reoperation, and the reoperation is usually, the majority are done because of autograft dilation and recurrent aortic regurgitation. So risk factors for that: age, being male, aortic insufficiency as the indication, and larger annuli. This is maybe one of the other most important papers to come out about the Ross procedure, and this is real world data. It's the German Ross registry. So in Germany, these patients, all Ross patients from 1988 until now, are enrolled and carefully followed in the registry. So looking at almost 2,500 patients with a mean age of 44 years, what are the results over the long term? So again, this is, as has been found in many series before, if you look at the Ross patients compared to the general population, matched general population, there's no difference in long-term survival. If we look at reintervention, so this is a little higher incidence. And so that's maybe the difference between single center expertise, single surgeon, relative to registry data, looking at risk of reintervention of about 20% at 20 years. So somewhere between 20% at 20 years and 10%, according to Tyrone David's series, that's what you're looking at for risk for reintervention. Are there some risk factors that you could sort of mitigate? And that has been addressed with some of the refinements of the procedure lately. This is from Laval, 310 patients, mean age 41 years, follow-up 15 years. A lot of these, 73% were bicuspid aortic valves, you'll note, and annular size, kind of average annular size of 23. Okay, so what are the predictors of graft failure? A larger annulus. So particularly over 27, an annulus over 27, preoperative aortic insufficiency, and getting into the idea of more of an aortopathy related to bicuspid valves if the ascending aorta was replaced as well. So there is a subset of patients with suboptimal anatomic substrate. Dr. David wrote about this, suggested the predictors of late failure of the autograft or pre-op AI, larger annulus, and a mismatch between the aortic and the pulmonary valves. So to address that, the Ross procedure has been modified through the years, and modern day contemporary strategy, the one that we are using in Calgary, is to do a full root replacement that maintains the dynamic function aortic root, allows for the living valve substitute to function the way it should, but it supports both the annulus as well as the sinotubular junction. Now that's done with Dacron, using a Dacron tube graft, and segment of the Dacron tube graft is removed, and that's sized based on the pulmonary artery. So if the pulmonary artery size is to a 27, then we put in a 32 annuloplasty ring. So the Dacron would be 32, and that's placed around the annulus right at the base. This is a video showing that sutures have passed underneath the valve, just underneath the annulus, and exterior. Okay, so this is a root dissected right down to the basal ring, and you can see both these sutures placed in a mattress fashion. So, anywhere between 4 and 8, we usually put about 6 sutures to stabilize the annulus. This is the Dacron ring in situ, and it stabilizes the annulus over the long term. So Scott McClure and I, together with Paul Fedak, wrote an article recently suggesting that this is the bespoke Ross procedure. So this is tailoring the Ross to the substrate. And so some patients have suboptimal substrate. This is a means of addressing it, improving the long-term durability of the operation. So the bespoke Ross procedure would be done with an external ring annuloplasty in patients' primary aortic regurgitation, if the annulus is enlarged, or if the pulmonary valve is much smaller than the aortic valve annulus, to bring that aortic valve annulus into the same dimensions as the pulmonary valve. Replacing the ascending aorta is done if the ascending is over 45 millimeters. And in the absence of replacing the ascending, doing an STJ annuloplasty, so a small ring of Dacron at the distal suture line at the sinuses of the top of the sinuses, is done if the ascending is over 4 centimeters. So let's look at indication. So when do we want to do a Ross procedure? Well, again, it's young and middle-aged adults with unrepairable aortic valves. If the valve is repairable, that's still the best option. However, if the valve is not repairable, and that's true in the majority of patients in this cohort with bicuspid valves, then a Ross procedure is the best alternative option. Of particular benefit are patients with high levels of activity, and this brings us back to the living valve, and when you put a valve, there's a degree of patient prosthesis mismatch in most patients that get prosthetic valves, and particularly for patients that are active, high activity level, the size of the struts, the size of the sewing ring, this all leads to non-laminar flow and leads to a degree of obstruction and patient prosthesis mismatch. So in those patients, the Ross procedure is a true benefit. So high levels of activity, or women contemplating pregnancy when anticoagulation can be avoided. So if they have ideal anatomy, so that would be if the annulus is small, then a standard Ross technique can be used. If you have suboptimal anatomic substrate, as we just talked about, AI or predominant AI, dilated annulus, mismatched aortic pulmonary sizes, then you do a bespoke Ross with annular stabilization plus minus replacement of the ascending aorta. Now, we have only done 10 cases in Calgary to date. When I spoke with Ishmael about this recently, he said, "That's fine, man. I did only 10 in my first year doing the Ross procedure." So I think we would have probably done double that if we weren't slowed down because of COVID. Certainly the patients are there, but I feel that it's important for us to present our early results, or very, very early results, of course, and to compare those with what's done in the German Ross registry. Our mean age, 44 years. The majority of those were male. Mean annular diameter, 26, compares to 27. So we have done the larger annulus, patients with larger annulus, predominant lesion, For us, 40% was regurgitation. This is sometimes depends on your definition, whether it's mixed or regurgitation predominantly, especially with bicuspid valves. 90% of ours were bicuspid to this point. A bypass and clamp time, it does take a while to become facile with this operation. We were a little slower on the first few cases, and our times are somewhat longer than what was reported in the German Ross registry. Our 30-day mortality, of course, is 0. And that compares with, again, this is registry data with 1% mortality, compares very favorably to mortality rate with conventional aortic valve replacement. Other surgical details, we did an annuloplasty, about 50% of them replaced the extending, and 60. Mean gradient of 7.6 across the 10 patients. None had significant aortic regurgitation. Length of stay on average 9 days. No strokes. 1 readmission for pericarditis, and 1 patient required a pacemaker. The other important point, part of the new strategy with the Ross procedure in its resurgence is controlling blood pressure. And this is very important as the pulmonary valve adapts to its new higher pressure environment. So we keep the blood pressure 110 to 115 systolic for 6 to 12 months. And we're very particular about that. I actually give my cell number to all my Ross patients and have them text me their blood pressures regularly until we get the blood pressure stabilized and under control. So, you know, we've been a leader in Canada throughout this resurgence of the Ross procedure. And since Ishmael started his program in Montreal, there's now been, in 2012, started in Kitchener, in Toronto, Hamilton in 2016, Quebec City in 2017. In 2018, started in Vancouver with Dan Wong, who helped us too here in Calgary when Scott and I were starting. And then, as I said, we did our first case in February of 2021. Edmonton did their first this last fall. So to summarize all this, key messages, I think, I encourage you to read more about the Ross procedure and look more at the data. I've given you a brief summary of it today, certainly not all of it. But Ishmael in his article, this was a response to the paper on the German Ross registry. He's very eloquent in his discussion of the Ross procedure, and I love his point of it's a living aortic valve substitute, which has advantages of durability and functional, a greater functional status in the environment of the aortic root. If you're going to read one article, this is the greatest summary. It's like from Amin Mazin, written together with Ishmael, and this was published in 2018. It summarizes the data, the rationale. It's a great article. Now, how does all this evidence, how is it represented in the guidelines? The guidelines always lag, of course, and we all know this, and that's certainly true for AHA ACC guidelines, which would suggest that maybe you consider the Ross procedure in a patient under 50 years old only if they would prefer a biovalve, okay, not mechanical. And then you can maybe only consider if it's done at a center of excellence in valve surgery. So class 2B recommendation, so not at all strong. So I would suggest that in summary, the Ross procedure warrants a recommendation higher than 2B. It's ideal for stenotic valves, smaller annuli, young active patients. And its advantages: best survival, no anticoagulation, low rates of valve-related complications, endocarditis is negligible, thromboembolism, bleeding, and it has superior hemodynamics. Downside, the surgical complexity. It's a bigger operation, but when done in centers of expertise, it can certainly be done with low perioperative mortality. There's always been the argument of converting single vessel disease to double valve disease. And accessibility. Not everybody is a candidate because they don't have a referral pattern with access to centers of expertise in valve surgery. So, what makes this all worthwhile? And this was a text I got from one of our patients. He texted me because he was sending me all his blood pressure. So he texted me, said, "It's my 39th birthday. I wanted to tell you how grateful I am. It's been 5 weeks." There he is in the hospital. 5 years later, he's out drinking red wine, and he's in Banff with his wife. So, I mean, this is what you want for young patients with long life expectancy. So with that, thanks very much for listening. I really appreciate it. I appreciate you giving me the time, and happy to address any questions.
So that was a great whirlwind summary, Bill. It sounds like what's old is new again, but newer and better. If you guys have questions, please enter it in the chat, or if there's a block of silence, feel free to turn on your microphone and jump in. While we're waiting, the excitement that you have for this procedure, clearly comes through. Could you project for me out, say 2 or 3 years from now, hopefully when we're not COVIDing anymore and we're not having any OR restrictions, and you've had you and Scott and the other members of the team have more cases under your belt, like what percentage of cases ultimately do you think will revert to the ROS that we would have otherwise done in other ways?
Yeah, it's a good question. I think it's hard for me to know. I think we're scratching the surface a little bit to a degree. I mean, that young patient population, I think if partly related to this question is, well, where would you go in terms of age? Would you go out to like above 50? And yes, I think some of those patients are candidates, particularly if they got life expectancy greater than 15 years. So if you include the young patients, which are a relatively small number, but then you look out to patients into their 50s, maybe up to 60, most would suggest, most ROS programs would suggest that you're a candidate up till then. Well, then I think we're looking at a larger proportion. And I would say, 3 times sort of if we're doing 10 the first year, we're looking at probably a volume of 30 a year, I would expect. And so that's, maybe 25% of our aortic valve volume potentially, as a ballpark estimate.
And these patients do they get followed annually by you? You've talked about the valve clinic. Maybe you could talk a little bit more about the valve clinic. Is that a short-term follow-up, or are they yours for life at that point, or?
Yeah, I mean, I've always had mixed messages in the valve clinic. Part of the reason for the valve clinic is that, some have said to me like, yeah, you're just wasting your time seeing all those patients repeatedly because they've got cardiologists. Well, that's true. Some have great cardiologists that follow them very, very carefully. But there's a large cohort especially from rural catchment areas, which are not followed by cardiologists. So I think, for the valve clinic is important for that. But the other big thing, and the reason Andrew and I wanted to start it was for the data and to carefully follow our outcomes of valve patients longitudinally over the long term. And so we have, 100% follow-up with our model, like the Montreal Heart. And I think we can learn a lot about what is the best operation for our patients if the more data we know. I mean, we've struggled with recording that data, but, and much of it's on paper, but it's all there. So I think that's important.
I think there's a lot of potential. Many of us know that one of Paul's visions for both the department and Libin is really to try to make that data easier to collect and more importantly, to use, especially by linking it with lots of other streams of data. It's amazing. AHS, I think, knows everything about everyone in the province, but it's scattered over so many different databases that the challenge is trying to get the information together, right? So I think there's real potential if we keep doing what you're doing.
Yeah, thanks.
Bill, congratulations on this work. Congratulations to you and Dr. McClure and all the team members involved. I mean, one of the things that, you're an outstanding surgeon and you're very bold and you're just doing amazing things for our section and for our patients. So kudos to you for sure. And that was an excellent, excellent presentation. I do want to ask you a question about the important role, and we're talking about the clinic and follow-up. There's no question you can probably do anything in the OR, but the good long-term results require all the members of the perioperative team and follow-up to participate in the program. And I know you've done a good job of linking everyone in. Can you tell us just a bit more about, blood pressure control and follow-up, and how do we go forward, as a program to make sure that these patients do really well. There's no question you can do the technical surgery, but we need all hands on deck to get the kind of great outcomes that these Ross programs have. So maybe given the sort of multidisciplinary turnout we have, which is great, maybe you could talk a little bit about that.
Yeah, well, thanks, Paul, and that's very generous comments. And I certainly have appreciated Paul's support of our program and in starting our Ross endeavors. So it's greatly appreciated. And I think it's really exciting that we have a lot of new technology that's going to help us tremendously in following our patients. And I think we're just on the cusp of this. And so I think all this data that I just went through, a lot of the good outcomes are because patients are carefully followed. Their blood pressure is managed. They know about antibiotic prophylaxis. They're on the right medications for LV remodeling and all this. And so the closer valve patients are followed, the better they do. I think we certainly know that. And that's especially true for Ross patients. And maybe that's a lot of the reason why their long-term survival is so superior to conventional AVR, particularly in this registry data. These patients are, surgeons have a lot of skin in the game with these. They're really invested. And so it does speak to the importance of follow-up. We do have the infrastructure for that with the great cardiology group we have in this city and with our valve clinic, I think. And as app-based new technology comes along, and I know that we're going to be discussing this as a group. I think you're chairing a meeting soon, Paul, about this. All this new technology is going to allow us to target blood pressures, to follow our patients, to get real-time results on their clinical state. And that's really exciting, I think. That's really exciting for understanding our patients and how they do. And it's really exciting because it's going to provide much better management and outcomes for them.
Yeah, well, absolutely well said. Tell us a little bit more about your vision for becoming a valve center of excellence. I mean, I think we already are, but what are the sort of criteria and how can we all work together to really be a world-class valve center of excellence?
Yeah, I mean, this has always been we've talked a lot about this, Paul, and I mean, I really think we have the potential. What we don't realize sometimes is first of all, our volume and how important we are on the North American stage. I mean, we think of ourselves as out in Western Canada isolated, but just the nature of public healthcare means that we are a very high volume center. So when we talk to surgeons in the US or centers in the US and say that we do 2,000 cases a year and what our valve volumes are, they're blown away, because as many of you know, when you work in the US, it's very fractured. There's a lot of little small hospitals. It'd be like if in Calgary, the Rocky View was doing 200 cases a year sort of thing. So there's a lot of that. And it leads to, not the same benefits of having large cohesive teams doing high volume. So we have this opportunity to be a real leading center just based on our volume and the team that we have and the talent. I think we sort of utilize that at times. We're very Canadian in the sense that we don't promote ourselves the way that we should. So we've got great people. We've got the infrastructure here. I think we can grow this and we can be more involved in clinical trials. We can, evaluate our outcomes and sort of understand our patients better with time. And I think we've got a great group to be able to do that. And I think, and we should be on the national, international stage talking about our valve outcomes and what we do here.
Agree 100%. Very exciting. Okay, I'll be quiet now. Good job.
Thanks.
So Bill, there's a question from one of the users. I believe it's Yorgo, but hard to tell. And he is excited about the low reoperation rates at 10 to 20 years that you reported. But those of us that have known Yorgo for many years know that he's a skeptic at heart. And he's wondering if there are many patients with moderate or severe valve disease that aren't being reoperated upon, but maybe living with dysfunctional valves, and was wondering if you had any data on how the valves themselves function.
Yeah, so that's a good question. There is a lot of data on that, actually. So the most common, as you know, and as we talked about already, is autograft dilation. So that's the most common thing. Second would be And that happens about 1% per year, per patient year. So there's a sort of an inflection point around 15, 20 years where you start to see, and that's about roughly 10 to 20% of patients start to develop autograft dilation and AI. And then the pulmonary homograft can stenose over time and lead to RV dysfunction. So that's a little less common. That's about less than 0.5% per patient year over time. So most of those can be dealt with percutaneously with a Melody valve or a Sapien valve in the pulmonary position, so don't require reoperation. The interesting thing is, even though this 20%, 10 to 20% of patients get reoperations, it doesn't appear to affect their long-term survival. So, and that's what the data would suggest. So even though they're getting re-opt, they do well with it. And I've done 4 of those. I've done 2 of Andrew's cases and 2 of Tyrone David's, 3 of them for autograft root dilation. In all 3 of those cases, I've saved the valve, so they still were left with their pulmonary valve. I did a David procedure, and they had, saved the valve leaflets, which looked actually pristine. It was remarkable for me to see. It was part of the reason of my enthusiasm to start doing the Ross again. And then the one that was the in those cases, the pulmonary valve was a autograft stenosis, or inflammatory reaction that had happened earlier and progressed. I got to say, the homograft and the 3 that I did for the root dilation, it looked like the day it was put in. It was unbelievable. So you get these certain patients that have an inflammatory reaction to the homograft. Hopefully that's less common with the decellularized cryopreserved homografts that we're using today that weren't used in the past. I think I've answered most of the questions there. Yeah, that's a very good question. I mean, obviously, yeah.
That was almost like the back to school final exam question, where we only have one question with 23 parts. Bill, with that, I'm going to let you go. That was a great session, both in terms of science from elsewhere, but exciting to hear about the great work that you guys are doing here and how we're really improving the lives of patients in Alberta and surrounding areas. And I want to thank you for that, and come back anytime. I look forward to hearing an update on how this is going in a couple of years.
Well, thanks very much. I appreciate for all of you for coming and listening to this. I think it's an exciting time for us in Calgary, and I think we can accomplish a lot. So appreciate you taking the time this morning.
Bye, everyone. Have a great day.